Dr. Ken Landau, thanks for watching. Let's talk about some cardiovascular and blood-related problems associated with COVID-19. Now, most people think of COVID-19 as a respiratory infection and difficulty breathing and pneumonia and mechanical ventilation, but it's a lot more than that. And as a matter of fact, we know that probably 40% of people who die of COVID-19 either die because of cardiovascular problems alone or in combination with respiratory failure. And those people who have the greatest risk are older individuals, people who have hypertension or diabetes, people who are cigarette smokers, people who have some kind of cardiovascular history. So you've had a heart attack, you've had angina, something of that nature. Well, all of those conditions put you at risk for atherosclerosis, and not only atherosclerosis, causes abnormalities of the endothelial cells that line the blood vessels, and that seems to predispose to the heart-related issues, and it predisposes to the blood clotting-related issues. So by the time of hospital admission, somewhere around 20 to 30% of people already have some evidence of cardiovascular injury. The heart is damaged. And during hospitalization, that number increases to somewhere around 40%. And it seems that those conditions that we mentioned, the history of hypertension or diabetes, whatever, they all increase the likelihood that you're going to have the condition. First of all, you're more susceptible. Two, you're more susceptible to the adverse complications. You're more likely to be put into the intensive care unit, you're more likely to require mechanical ventilation, and you're more likely to die if you have any of those underlying conditions. Now, this isn't new. So we've known for 100 years that after you suffer some kind of pulmonary infection, whether it's influenza or whether it's pneumonia, even relatively mild pneumonia, we call it community-acquired pneumonia, you may have an increase in the incidence of heart-related events. You have a greater risk of having a heart attack after you have the influenza. And especially if we look at the 3 or 4 days after you suffer the influenza or the pneumonia, your risk is increased for a cardiovascular event, a heart attack, by anywhere between 3-fold and 100-fold compared to what it would be the week before or the year after. And that's because when you're infected with the virus or the bacteria, under normal circumstances, that stimulates the body's immune system. And you have a tendency to have more clotting in the system. You activate the macrophage, a type of white blood cell that's associated with the inflammatory response, and that leads to the increased risk. And that's why the flu shot seems to do something. Even if it doesn't prevent the flu, it oftentimes damps down the immune system. So if you are infected, it's not going to be nearly as bad. Well, with the coronavirus, there are 3 stages of the infection. There's the early phase. That's when the immune system is just being stimulated. Then we have the pulmonary phase. Now you have some symptoms and you have significant inflammatory reaction. That's when the oxygen level in the blood might be significantly reduced. That's when those monophages and macrophages, type of white blood cells, are being really stimulated. And then finally we have the severe hyperinflammatory phase. That's when you're in the intensive care unit, you're receiving the mechanical oxygenation. That's when you're at difficulty. And that's because of the immune system that's hyperstimulated. Your body has an immune system that's running out of control. So if we look at cardiovascular injury, we find the older you are, the greater your risk. But we find that there are certain kind of markers we can find in your bloodstream that are the same kind of markers we would find if you had a heart attack and you were in the hospital. We draw those same kind of tests and find the same kind of chemical is elevated after a heart attack as it is when you go to the hospital with COVID-19. Not only is the troponin I and the troponin T elevated, but we also find some of the other markers associated with heart disease that are increased right at the time of hospitalization. And then in many people, those numbers increase during the course of hospitalization. These are the same things that we would find with a standard heart attack, or what's known as a type 2 heart attack. Type 2 heart attack is when the heart is not receiving enough oxygen to fulfill the demands of the body. There's a mismatch in supply and demand. Or a person develops myocarditis, inflammation of the heart, either because of the virus or because of the immune reaction, typically the immune reaction. You can develop heart failure, pulmonary embolism, impaired renal function, all of this during the course of the COVID-19. And it seems that not only can we find markers in the blood that say the heart has been damaged, but we also find markers that say the heart cells are being stretched. The heart is not pumping as well as it should normally. And then we also find markers that say your blood clotting system has been activated, things like the D-dimer and some of the fibrinogen or the factor VIII, all somewhat abnormal. So if we look at people who are taken to the hospital with COVID-19 and they don't have any cardiovascular risk and they don't have any increase in the titer of the troponins, we find that the risk of death is about 8%. Now, if they only have cardiovascular risk, you have hypertension, you have diabetes, then your likelihood of death increases to about 13% if you don't have any evidence of myocardial injury. On the other hand, if you have the myocardial injury, but not a history of hypertension or diabetes, then your risk is about 40% for dying if you happen to have both. So when you go to the hospital, you already have the history of hypertension or diabetes or your cigarette smoking, and you also have increase in those markers that say the heart has been damaged, then the risk of death can be as high as 70%. So it seems that the troponin level, that's the level that we use to monitor heart damage, heart muscle damage, well, we find that that's actually the second leading predictor after ARDS, acute respiratory distress, of increased risk of death. We also find increased that if your troponin is up, your platelets are more likely to clot. You're more likely, if you've had a stent, to have a clot right inside the stent. Now, we think of the disease, again, as just being a lung disease, but those receptors that the virus uses to get into the lung cells also happen to be in the heart and in the blood vessels, on those endothelial cells, the cells that line the inside of the vessel, and they're also in the intestine and a variety of other places. So we find that they're starting to describe an endothelialitis. That means an inflammation of the cells lining the blood vessels, and they can be directly attacked by the virus. And when those cells are injured, they have a tendency to vasoconstrict, to cause the artery to narrow, or the vessel to narrow. And then the vessel becomes inflamed, the flow becomes slower, and when we have slow blood flow, it has a tendency to clot. So we find that there are inclusions, and we find that not only is the virus there, some of the cells lining the vessels actually die. Well, that can explain a lot of why people develop the myocarditis, why people have acute heart attacks associated with COVID-19, why people have the heart failure associated with it, all because of damage to the endothelial cells. And again, the people who are at most at risk are those people who have the standard kind of suggestions that they might have impaired function of the endothelial cells, the cigarette smokers, the people with hypertension, the people with diabetes, the older individuals, even if you don't have any symptomatic coronary artery disease. And what's the cause of all the problem? Well, the cause seems to be something we know as a cytokine storm. And a cytokine storm can be caused by either a virus infection or a bacterial infection, or it doesn't even have to be an infection at all. But it leads to tissue damage and cell injury. The concept was popularized around the 1990s when there were some of the graft versus host reactions. This explained the condition. But it was really well known in the 2005 avian flu epidemic. And when that happened, we realized that the immune system being stimulated and not contained could cause significant problem. We have a systemic inflammatory response, or some people call it SIRS, S-I-R-S, instead of SARS, S-A-R-S. And it can lead to a myocarditis, inflammation of the heart wall, even though we don't have the actual heart muscle cells being infiltrated by the virus, but we do have the endothelial cells. Well, what is a cytokine storm? A cytokine storm is the result of stimulating the body's immune system. So it's associated with a variety of factors, interferon and interleukin and the chemokines. They cause the inflammation. They cause the blood cells, the white blood cells, to infiltrate an area. And then those cells grow because of some other kind of cytokines, some colony-stimulating factors, and they all seem to have to do with the tumor necrosis factor, TNF. So all of that's going on, a very complicated series of events. But if we drew your blood, we could find that those are elevated in the bloodstream. So you can imagine what they're doing in the local area in the tissue that we can't measure. Well, myocarditis is inflammation of the heart muscle. World Health Organization defines certain kind of criteria. Well, they require biopsy and a variety of other problems, other interventions that obviously we're not going to do. But it seems that this myocarditis can cause life-threatening complications in people who don't otherwise have anything wrong with their heart. And it seems that it's the cytokines that are causing the problem. And the cytokines are causing the problem not only in the lung, but in the heart and in the smooth muscle and in the endothelial cells lining the vessels. And then that's all infiltrated by inflammatory cells from the immune system and the white cells that are making a variety of other kind of chemicals. Well, all of this is further compounded when you're very sick. Your electrolytes, the sodium and the potassium, are very good, and the oxygen level is going to be down, and all of that is going to lead to an exaggerated response. So you might have some chest pain, or you might have shortness of breath, you might have some arrhythmias. And the question is it caused by the lung disease? Is it caused by the myocarditis? Is it caused by your having a heart attack? That can be very difficult to distinguish all of them. And then on top of it, we have arrhythmias. We can have simple arrhythmias. We can have a tachycardia, tachyarrhythmia, where the heart beats just very fast. About 3/4 of the time it does because of the fever, the increased metabolic needs, the lower oxygen level. And sometimes it beats very slowly, but in maybe 5 or 10%, people can develop some ventricular tachycardia, and that can be potentially life-threatening. And especially if we look at the people who are in the intensive care unit, well, the evidence of ventricular tachycardia increases quite significantly. Increases when the metabolic demands on the heart are increased and the oxygen going to the heart are decreased, and on top of it, we stimulate the heart with what are known as catecholamines, the adrenaline and the similar substances. And all of that leads to an increased damage to the heart muscle cell and more of those troponins being released. And sometimes we get hypotension. The blood pressure can go down. We can get heart failure. The heart isn't able to adequately pump enough oxygenated blood to the different tissues. Now, heart failure is a very common condition. It occurs in about 6 million people. So that means a significant number of people with heart failure who are doing otherwise well are going to develop the coronavirus infection. And when they do, they're going to decompensate oftentimes. Now, congestive heart failure, when it occurs, that means your heart isn't pumping adequately. So if it's the left ventricle isn't pumping adequately, the fluid's going to fill up in your lungs, which are already have too much fluid in them. Or if the right ventricle isn't working well, then you're going to get some swelling of your feet and abdomen, and perhaps you're going to have some difficult time lying down. You're going to be fatigued. Well, under most circumstances, the congestive failure is caused by either hypertension or bad coronary artery disease, previous heart attack, maybe you weigh too much, you have diabetes, or you have some kind of a valvular problem. But in a significant number of people, it can be brought on either by the virus itself or can be just made worse because now you have all of the extra metabolic demands and your heart was just barely able to compensate under normal circumstances with you going from the chair to the kitchen or something of that nature. And then, making matters even worse, when you get sick, you're given intravenous fluids where your body can't take care of the fluid that you already have in your blood, and now we're giving you extra fluid. And as a consequence, we can have significant problems even if you don't have significant obstruction to your coronary arteries. So that's the message. The clotting inside the system, the inflammation inside the system, all is sufficient to cause a variety of cardiovascular problems in the absence of what we would consider significant coronary artery disease. Now, you can even have a heart attack because of those kind of complications. And unfortunately, all of this tends to stimulate the clotting mechanisms in the body, and you form a variety of tiny microclots, and those microclots form in the heart, obviously not good, the lungs, and as a matter of fact, if we look at people who pass away because of what we think is pneumonia, oftentimes in COVID-19, it may well be because of just a variety of clots inside the lung, but the clots also occur in the kidneys and in the intestines and deprive those areas of oxygen, and then you can go on to develop multi-organ failure. Well, seems that those white cells, the inflammatory reaction, all of that has significant impact. So we can even find people who don't have any obvious pulmonary symptoms, but they've stimulated the immune system enough so that you can develop all of a sudden, first signs would be chest pressure, chest tightness, fatigue, might even have a heart attack as a result. So we can find that you have elevated levels of those troponins in the system, or you can have an abnormality of the electrocardiogram. It's not infrequent now for otherwise young, healthy people all of a sudden to die, sudden cardiac death. Is it due to arrhythmia? Is it due to a heart attack? Is it due to some other kind of a problem, myocarditis? We just don't know, unfortunately. But it can occur either early in the course of the disease or even late, after it seems that the respiratory problems went away. Well, the respiratory problems may go away. You may heal from the COVID-19, but you still have the clotting abnormalities. You still have the tendency to develop the pulmonary emboli, the clots. And now all of a sudden we're finding an increased incidence of stroke in people who have COVID-19. Stroke that would otherwise occur in people in their 70s, now all of a sudden is occurring in people in their 30s and their 40s. Now, stroke is a complication about 5% of COVID-19 cases, but all of a sudden it may well now be found as the first presentation of the condition. So otherwise healthy people all of a sudden have a difficult time walking or speaking, or they have drooping aside of the face. The CAT scan shows multiple different areas of infarction in the central nervous system. Blood gives us a hint that it is hypercoagulable. We find an increased number of people dying at home. Do they die because of stroke? Do they die because of sudden cardiac death? Do they die because of some other condition? Unfortunately, people aren't autopsied, so we don't really know what the toll is. But we do know that the clotting system is going to be stimulated, and the clotting system, once it's stimulated, can lead to problems. Now, anybody who's in the hospital, anybody who's not moving around, is at risk for blood clots. Blood clot in the leg, and then that can break off and go to the lung, or blood clot somewhere else. Well, that's why, of course, you're told if you're going to get on an airplane and go for a long distance, every hour or so, get up and walk around, so you don't develop the clot, because the slow-flowing blood has a tendency to clot. Well, these individuals who have COVID-19 have a tendency to clot well in excess of most other diseases. It just seems that the cytokine storm associated with the condition, with all of the different kind of chemicals that are being produced, leads to a hypercoagulable state and atypical presentation. So, for instance, there's something called lupus anticoagulant, or the antiphospholipid syndrome, that may develop. This is associated with blood clots, especially prominent in pregnant women or women who seem to lose their pregnancies. Well, it's the same kind of abnormality that may develop. And it may be in a very significant percentage of people. So if we look at the clotting abnormalities, among people who die of COVID-19, clotting abnormalities are present in over 70% of the people versus a relatively small percent of the people who don't die of the condition. So we have a systemic coagulopathy. And the coagulopathy is involving the lung and the heart, the brain, the intestine. And at the same time, some individuals, especially pregnant women, at the time of cesarean section, they seem to develop bleeding problems. So we have two different kinds of situations. The coagulation, the blood clots, obviously much more frequent than the bleeding abnormalities, but that leads us to the problem of, do we anticoagulate people who have COVID-19? And the answer would appear to be yes, and as a matter of fact, it seems that those people who are anticoagulated with COVID-19 seem to do better. We're talking about the hospitalized patients. They seem to have longer time to progression of the disease, and they have a decreased incidence of total fatality. So it seems that just allowing something to buy time so the body can heal itself is obviously very important. Now, the anticoagulants aren't an answer for some people. So some are at increased risk anyway, especially if you happen to be obese or you have a history of previous blood clots, or you're on what we call vasopressors, medicines to keep the blood pressure up because you're so sick that the blood pressure is falling down. You have what we call hypotension. Well, we have this condition that we call thromboinflammation, where all of the changes because of the inflammation in the system lead to the increased blood clotting. So it's related to the inflammation and it's related to the blood clotting, and we find that we can monitor that with fibrinogen and the D-dimer and other kind of chemicals that we can monitor inside the body. And some people have blood clots that get into the lung. We develop pulmonary emboli. And if we look at people who have acute respiratory distress syndrome with COVID-19 versus ARDS without COVID-19, we find that the people with COVID-19, 6 times greater likelihood of suffering pulmonary emboli. Then there's just a recently described condition with COVID-19. We've known about the condition for a long time. It's called Kawasaki's disease. It occurs in children. It was just described associated with COVID-19 in late April of 2020. It's also called the mucocutaneous lymph node syndrome. It's inflammation of the medium-sized arteries, and it can lead to dilation of the arteries, aneurysms of the arteries in the heart, in up to 25% of the individuals who suffer the condition. It's a pediatric condition. So children usually thought of as not having significant problem. Well, that's the group that Kawasaki's disease attacks. So in the first week or two, the arteries are inflamed inside the heart. Sometimes there's a myocarditis, weeks 3 to 4. That's when the aneurysms form, multiple aneurysms. And then they can go on to cause a heart attack in weeks 2 to 12. But if the child lives, and typically they do, then the aneurysms heal themselves in about 1 to 2 years. But sometimes when they heal, they can cause some extra narrowing or thrombosis inside the vessel, and that can lead to a heart attack in a 5-year-old or a 6-year-old. Now, it's more than just the dilation of the vessel, and more than just the heart attack, which, by the way, a heart attack in a 5-year-old or a 4-year-old isn't going to be the same, not going to present the same way as it does in an adult. Going to present with some shock or vomiting or just unrelenting abdominal pain. Well, a person can also develop arrhythmias and tachycardia and myocarditis and heart valve problems. Manifestations of Kawasaki's, well, it's at least 5 days of fever, so we can rule out some of the other more common respiratory ailments. The fever isn't responsive to ibuprofen or to acetaminophen. The temperature tends to be 101 to 104. Then you have to have at least 4 or 5 other components. The components would be a rash on the skin, mostly on the torso or in the groin, lymph nodes that are swollen in the neck, conjunctivitis, red eyes, both sides, bilateral, asymptomatic, don't have any problem with it. But then you have some oral mucous membrane problems. The lips are bright red, the tongue is swollen and looks sort of like a strawberry, cracks around the lip, peripheral extremities, the hands and the feet. The palms and soles are red, the backs of the hands and backs of the feet are swollen. It's the leading cause of acquired heart disease in children in developed countries, so it's not really an uncommon disease. 50% of the time it's in children less than age 2, 80% of the time in children less than age 5. No specific tests make the diagnosis, originally described by Dr. Kawasaki in Japan in 1967, first case in the US. 1976 seems more common in boys than girls. Wintertime, springtime, more common, very frequent in individuals of Asian ancestry or Afro-Caribbean ancestry. History of some kind of a viral infection within the past month, and that's indeed what seems to be happening. We've had the COVID-19 epidemic for a while. Now we're starting to see some of the complications, one of which appears to be Kawasaki's disease. Now, early on, it's very difficult to tell that that's the condition when the child just comes in with a little sore throat, a fever, fatigue, confusion, runny nose. That could be anything. But when it persists and when it doesn't go away and when the other kind of manifestations develop, then you know that there is indeed a problem. And the children can be very sick. They can require intensive care, mechanical ventilation, medicines to keep the blood pressure up. And guess what? Those troponins we were talking about, those are elevated. The treatment for the condition, intravenous immunoglobulin, aspirin. Now, some people take medicines as antivirals. So you've heard the story about the chloroquine and hydroxychloroquine or the ribavirin or some immunosuppressants, the HIV medicines and the corticosteroids. All of those can potentially lead to significant problem for the heart. So if we look at something known as a QT interval, well, if you don't have COVID-19 and you take a hydroxychloroquine, nothing much happens to that QT interval. On the other hand, if you have COVID-19 and you take a hydroxychloroquine, that QT interval is going to enlarge quite significantly. And the importance of the QT interval is that has a tendency to signal an increased risk for potentially fatal arrhythmias. And that's why taking hydroxychloroquine is not a good idea if you happen to have COVID-19. But a ray of hope in all of this. So COVID-19 is causing major problems throughout the world. But another coronavirus, OC43, it was thought to just involve cows until the late 1880s. Then it went from cows to humans. Actually went from mice to the cows originally, and then cows to humans in the late 1880s. And there was what was thought originally to be the flu epidemic of 1889 to 1890. Killed 1 million people. Well, now after investigation, it appears that it wasn't the influenza, it was the coronavirus, OC43, that went from a highly aggressive kind of a virus to now just the common cold. And that's what OC43 is now, just another cause of the common cold. So hopefully, with some time, we're going to find that this virus isn't nearly as virulent. So that's the story. That COVID-19, not just a respiratory ailment, involves multiple systems in the body, especially the heart, especially the brain, leads to an increased tendency to blood clotting in the vessels. That can cause major problems, obviously. And it's not just a problem with clotting inside the lung, it's a problem clotting inside the heart and problem clotting inside the kidney and inside the intestine. And of course, it's the body's overwhelming response to the infection that seems to trigger all of this. Triggers the cytokine storm, or what we call the systemic inflammatory response syndrome. Anyway, thanks for watching. If you enjoyed the show, please tell a friend, consider subscribing so you'll be notified when we post new videos. I appreciate your interest. I'm Dr. Ken Landau.